NAPLEX drug-drug interactions. Treat this like a real exam block. This is a full NAPLEX-style practice set, focused entirely on one of the most tested and most missed topics on the exam. In this video, you'll work through 100 exam-level questions designed to make you recognize dangerous combinations the way the NAPLEX presents them, through symptoms, labs, medication profiles, and clinical scenarios. A patient on warfarin 5 mg daily presents with an INR of 6.8 and reports starting trimethoprim sulfamethoxazole 3 days ago for a UTI. Which mechanism best explains this interaction? Option A, P-glycoprotein inhibition reducing warfarin elimination. Option B, displacement of warfarin from plasma protein binding sites. Option C, CYP2C9 inhibition combined with reduction of vitamin K producing gut flora. Option D, enhanced warfarin absorption due to altered gastric pH. Correct answer: C. TMP-SMX causes major INR elevations through dual mechanisms. CYP2C9 inhibition, reducing warfarin metabolism, and eradication of gut bacteria that synthesize vitamin K. This combination creates significant bleeding risk. PGP affects substrates like digoxin and DOAXC, not warfarin. Protein displacement is transient and clinically insignificant. Absorption changes don't explain the sustained INR elevation. A 68-year-old on apixaban 5 mg twice daily develops epistaxis and hematuria 2 weeks after starting clarithromycin for pneumonia. What is the most concerning reason for this clinical presentation? Option A, clarithromycin-induced thrombocytopenia, reducing platelet function. Option B, dual inhibition of CYP3A4 and P-glycoprotein, increasing apixaban levels. Option C, enhanced anticoagulant effect from clarithromycin's antiplatelet properties. Option D, competitive protein binding displacement, increasing free apixaban fraction. Correct answer: B. Apixaban is metabolized by CYP3A4 and transported by P-glycoprotein. Clarithromycin inhibits both pathways, dramatically increasing apixaban exposure and bleeding risk. Macrolides don't cause thrombocytopenia or have inherent antiplatelet effects. Protein displacement doesn't explain sustained elevation of drug levels with DOAX. A patient taking clopidogrel for recent stent placement reports, the cardiologist wants to start pantoprazole for GERD symptoms. Why should the pharmacist recommend pantoprazole over omeprazole in this case? Option A, pantoprazole has superior acid suppression, reducing cardiovascular inflammation. Option B, omeprazole inhibits CYP2C19, preventing clopidogrel activation to its active metabolite. Option C, pantoprazole enhances platelet inhibition through direct P2Y12 receptor modulation. Option D, omeprazole causes gastric pH changes that reduce clopidogrel absorption. Correct answer: B. Clopidogrel is a prodrug requiring CYP2C19 activation. Omeprazole is a strong CYP2C19 inhibitor, preventing conversion to active metabolite and reducing antiplatelet effect, increasing stent thrombosis risk. Pantoprazole has minimal CYP2C19 inhibition. PPIs don't directly affect platelet receptors or significantly alter clopidogrel absorption. Acid suppression doesn't reduce cardiovascular inflammation. A pharmacy receives a new prescription for tramadol in a patient currently taking sertraline 100 mg daily and sumatriptan as needed. What is the most dangerous potential outcome if this combination is dispensed? Option A, respiratory depression from additive CNS depressant effects. Option B, seizure activity from lowered seizure threshold. Option C, serotonin syndrome from excessive serotonergic activity. Option D, hypertensive crisis from norepinephrine accumulation. Correct answer, C. This triple serotonergic combination, SSRI plus triptan plus tramadol, creates high risk for serotonin syndrome, characterized by hyperthermia, clonus, and autonomic instability. While tramadol can lower seizure threshold, serotonin syndrome is the most immediately life-threatening outcome with this specific combination. Tramadol alone doesn't cause significant respiratory depression at therapeutic doses. Hypertensive crisis occurs with MAOIs and sympathomimetics, not this combination. A patient on lisinopril 20 mg daily and spironolactone 25 mg daily presents with weakness and a potassium level of 6.2 mmHg/L. Which additional medication on the profile is most likely contributing to this critical lab value? Option A, amlodipine 5 mg daily. Option B, metformin 1000 mg twice daily. Option C, trimethoprim sulfamethoxazole DS twice daily, started 5 days ago. Option D, atorvastatin 40 mg daily. Correct answer, C. This patient has triple potassium-retaining therapy, ACE inhibitor, blocks aldosterone, spironolactone, aldosterone antagonist, and TMP-SMX, trimethoprim blocks ENaC channels causing potassium retention. This combination frequently causes life-threatening hyperkalemia. Amlodipine, metformin, and statins don't affect potassium homeostasis. A patient stabilized on phenytoin 300 mg daily for seizure control starts ciprofloxacin for a complicated UTI. 3 days later, the patient experiences a breakthrough seizure. What is the most likely explanation? Option A, ciprofloxacin lowered seizure threshold through GABA antagonism. Option B, ciprofloxacin induced CYP metabolism, reducing phenytoin levels. Option C, ciprofloxacin chelated with phenytoin in the GI tract, reducing absorption. Option D, ciprofloxacin enhanced renal clearance of phenytoin. Correct answer, A. Fluoroquinolones lower seizure threshold by GABA receptor antagonism, which is particularly dangerous in patients with epilepsy on antiepileptic therapy. While FQs can chelate with divalent cations, phenytoin doesn't chelate. Ciprofloxacin doesn't induce CYP enzymes, it's an inhibitor, or enhance phenytoin renal clearance. The breakthrough seizure resulted from the proconvulsant effect of ciprofloxacin, not from reduced phenytoin efficacy. A patient on amiodarone 200 mg daily has a digoxin level of 3.2 nanograms per milliliter, therapeutic 0.5 to 2.0, and reports visual disturbances and nausea. The digoxin dose has been stable at 0.125 milligrams daily. Which mechanism explains this toxicity? Option A, amiodarone displaces digoxin from tissue binding sites. Option B, amiodarone inhibits P-glycoprotein, reducing digoxin renal elimination. Option C, amiodarone enhances digoxin absorption through gastric pH changes. Option D, amiodarone induces CYP3A4, converting digoxin to toxic metabolites. Correct answer, B. Amiodarone inhibits P-glycoprotein, the primary transporter for digoxin renal elimination, causing significant accumulation and toxicity, arrhythmias, vision changes, GI symptoms. Digoxin has a narrow therapeutic index, making this interaction clinically significant. Digoxin isn't metabolized by CYP enzymes. Tissue displacement and absorption changes don't explain sustained toxic levels. A 55-year-old taking simvastatin 80 milligrams daily develops severe muscle pain, weakness, and dark urine after starting azithromycin for community-acquired pneumonia. The CK level is 15,000 UU-liter. What is the primary mechanism of this interaction? Option A, azithromycin-induced rhabdomyolysis through direct muscle toxicity. Option B, CYP3A4 inhibition increasing simvastatin levels causing myopathy. Option C, competitive inhibition of statin uptake transporters in muscle tissue. Option D, enhanced renal elimination of protective coenzyme Q10. Correct answer B. Simvastatin is extensively metabolized by CYP3A4. Macrolides like azithromycin inhibit CYP3A4, dramatically increasing statin levels and causing rhabdomyolysis, elevated CK, myoglobinuria, dark urine, muscle breakdown. The 80 mg dose increases baseline risk. Azithromycin doesn't directly cause rhabdomyolysis or affect muscle transporters. CoQ10 depletion is a proposed mechanism of statin myopathy, but not the DDI mechanism here. A patient presents to the ER with rigidity, hyperthermia 40 degrees Celsius, and myoclonus. The medication list includes fluoxetine 40 mg daily, tramadol 50 mg 4 times daily, started 1 week ago, and ondansetron as needed. What should be immediately recognized? Option A, neuroleptic malignant syndrome from antipsychotic therapy. Option B, malignant hyperthermia from anesthetic exposure. Option C, serotonin syndrome from multiple serotonergic agents. Option D, anticholinergic toxicity from medication accumulation. Correct answer, C. Classic serotonin syndrome presentation. Hyperthermia, rigidity, myoclonus, clonus, from SSRI plus tramadol plus ondansetron. This requires immediate recognition and discontinuation of serotonergic agents. NMS involves rigidity but typically includes antipsychotic use and bradycardia. Malignant hyperthermia is anesthesia-related. Anticholinergic toxicity presents with dry skin, urinary retention, and mydriasis, not myoclonus. A patient on warfarin with stable INRs around 2.5 starts amiodarone for new-onset atrial fibrillation. What is the most appropriate monitoring plan? Option A, continue current warfarin dose and recheck INR in 4 weeks. Option B, reduce warfarin dose by 30 to 50% and check INR within 3 to 7 days. Option C, discontinue warfarin and transition to dabigatran. Option D, increase warfarin dose to overcome competitive inhibition. Correct answer, B. Amiodarone is a potent CYP2C9 inhibitor causing major INR increases over 1 to 2 weeks. Proactive dose reduction, 30 to 50%, with close INR monitoring prevents dangerous elevation. Waiting 4 weeks risks life-threatening bleeding. Switching anticoagulants isn't indicated for this manageable DDI. Increasing warfarin would worsen the interaction. This is a predictable interaction requiring anticipatory dose adjustment. A patient taking oral contraceptives starts rifampin for latent TB treatment. What is the most significant clinical consequence? Option A, increased estrogen levels causing thromboembolic events. Option B, reduced contraceptive efficacy due to CYP3A4 induction, leading to pregnancy risk. Option C, hepatotoxicity from combined estrogen and rifampin metabolism. Option D, rifampin treatment failure from competitive metabolism. Correct answer, B. Rifampin is a potent CYP3A4 inducer that dramatically reduces ethinylestradiol and progestin levels, causing OCP failure and pregnancy risk. Backup contraception is essential. The interaction reduces, not increases, estrogen levels. Combined hepatotoxicity isn't the primary concern. Estrogens don't affect rifampin efficacy. This is one of the most clinically significant DDIs requiring counseling and alternative contraception. A patient on metoprolol and verapamil presents with bradycardia, HR38, dizziness, and syncope. An ECG shows third-degree AV block. Which mechanism best explains this presentation? Option A, beta blocker overdose from verapamil, inhibiting metoprolol metabolism. Option B, additive negative effects on AV nodal conduction from both agents. Option C, verapamil-induced hyperkalemia, enhancing beta blocker effects. Option D, competitive binding at cardiac beta receptors causing paradoxical conduction delay. Correct answer, B. Both beta blockers and non-dihydropyridine CCBs, verapamil, diltiazem, slow AV nodal conduction. Combined use causes additive/synergistic suppression, leading to severe bradycardia and heart block. This is a contraindicated combination. Verapamil doesn't significantly inhibit metoprolol metabolism. CCBs don't cause hyperkalemia. The mechanism is pharmacodynamic, additive effects, not pharmacokinetic. A patient with bipolar disorder on lithium 900 mg twice daily presents with tremor, confusion, and ataxia. The lithium level is 2.1 milliequivalents per liter. Therapeutic, 0.6 to 1.2. Which recent medication addition most likely precipitated this toxicity? Option A, quetiapine 200 mg at bedtime started 2 weeks ago. Option B, lisinopril 10 mg daily started 10 days ago. Option C, lamotrigine 100 mg twice daily, stable for 6 months. Option D, lorazepam 1 mg twice daily. Correct answer, B. ACE inhibitors reduce renal lithium clearance by decreasing GFR and increasing proximal tubule reabsorption, causing toxicity. NSAIDs and thiazides have similar effects. Quetiapine doesn't affect lithium levels. Lamotrigine is stable and doesn't interact. Benzodiazepines don't affect lithium clearance. The timing, 10 days, aligns with ACE inhibitor initiation and lithium accumulation. A patient receiving carbamazepine for trigeminal neuralgia reports that her previously controlled seizures have returned since starting the medication. She has been on phenytoin for years. What explains this treatment failure? Option A. Carbamazepine competitively inhibits phenytoin binding at sodium channels. Option B. Carbamazepine induces CYP enzymes reducing phenytoin levels. Option C. Phenytoin induces metabolism of carbamazepine to inactive metabolites. Option D. Carbamazepine enhances GABA metabolism, reducing seizure threshold. Correct answer, B. Carbamazepine is a potent CYP inducer that increases phenytoin metabolism, potentially reducing levels below therapeutic threshold. This bidirectional interaction can also reduce carbamazepine levels. Both drugs don't compete at receptors. They have similar mechanisms, but the issue is pharmacokinetic. Neither enhances GABA metabolism. Breakthrough seizures indicate subtherapeutic phenytoin from induced metabolism. A patient on chronic opioid therapy with oxycodone begins taking fluoxetine for depression. 2 weeks later, the patient reports the pain medication is no longer effective. Which mechanism explains this reduced analgesia? Option A. Fluoxetine induces CYP3A4, increasing oxycodone metabolism. Option B. Fluoxetine inhibits CYP2D6, reducing conversion to active metabolite oxymorphone. Option C. SSRI-induced serotonin depletion antagonizes opioid receptor binding. Option D. Fluoxetine enhances P-glycoprotein efflux, reducing CNS opioid penetration. Correct answer, B. While oxycodone itself is active, some analgesic effect comes from CYP2D6 metabolism to oxymorphone. Fluoxetine is a potent CYP2D6 inhibitor, reducing this conversion. This also applies to codeine and tramadol, which rely more heavily on CYP2D6 activation. Fluoxetine doesn't induce CYP3A4. SSRIs don't antagonize opioid receptors. PGP effects are minimal for oxycodone CNS penetration. A patient taking tetracycline for acne reports taking the antibiotic with breakfast, calcium-fortified orange juice, and iron supplement. The acne hasn't improved after 4 weeks. What is the most likely explanation? Option A. Bacterial resistance developed from subtherapeutic antibiotic exposure. Option B. Chelation of tetracycline with divalent, trivalent cations, reducing absorption. Option C. calcium-induced alkalinization of gastric pH inactivating tetracycline. Option D. Iron competitively inhibits tetracycline binding to bacterial ribosomes. Correct answer, B. Tetracyclines chelate with divalent Ca2+, Mg2+, and trivalent Fe3+ cations, forming insoluble complexes that aren't absorbed, leading to treatment failure. This also occurs with FQs. Administration should be separated by 2+ hours. Resistance could develop from subtherapeutic levels, but chelation is the primary mechanism. pH changes aren't the main issue. Iron doesn't compete at the site of action. The problem is GI absorption. A 72-year-old on glyburide 10 mg twice daily develops confusion, diaphoresis, and a blood glucose of 38 mg per deciliter after starting trimethoprim sulfamethoxazole DS twice daily. Which mechanism contributed to this hypoglycemic episode? Option A. TMP-SMX enhanced insulin secretion through pancreatic beta cell stimulation. Option B. CYP2C9 inhibition, reducing glyburide metabolism and increasing drug levels. Option C. TMP-SMX caused acute renal failure, reducing glucose production. Option D. Displacement of glyburide from protein binding sites, increasing free fraction. Correct answer, B. TMP-SMX inhibits CYP2C9, reducing sulfonylurea metabolism and causing prolonged severe hypoglycemia, particularly dangerous in elderly patients on high doses. Glyburide already has high hypoglycemia risk. TMP-SMX doesn't directly stimulate insulin release or typically cause acute renal failure. While protein displacement occurs, sustained hypoglycemia is from reduced metabolism. A patient on stable levothyroxine 100 micrograms daily begins taking ferrous sulfate 325 mg daily for anemia. 6 weeks later, TSH is elevated at 8.2 MIU per liter, and the patient reports fatigue. What intervention is most appropriate? Option A. Increase levothyroxine dose to 125 micrograms daily. Option B. Separate levothyroxine and iron administration by at least 4 hours. Option C. Switch to IV iron to avoid the interaction. Option D. Add liothyronine to overcome the competitive inhibition. Correct answer B. Iron and calcium binds levothyroxine in the GI tract, reducing absorption and causing hypothyroid symptoms despite adequate dosing. Separating administration by 4 or more hours prevents the interaction. Simply increasing the dose doesn't address the ongoing binding interaction. Switching to IV iron is unnecessary and expensive. Adding T3 doesn't solve the absorption problem. This is a common, preventable interaction requiring patient education. A patient taking propranolol for hypertension is scheduled to discontinue clonidine due to side effects. What is the most concerning potential outcome if both medications are stopped simultaneously? Option A. Severe hypotension from loss of dual antihypertensive effects. Option B. Rebound hypertensive crisis from unopposed alpha receptor activity. Option C. Bradycardia from beta receptor supersensitivity. Option D. Orthostatic hypotension from impaired baroreceptor response. Correct answer, B. Beta blockers prevent the protective tachycardia response during clonidine withdrawal. If stopped together, clonidine withdrawal causes catecholamine surge with unopposed alpha stimulation, leading to severe rebound hypertension and potentially hypertensive crisis. Beta blockers should be tapered first, then clonidine withdrawn gradually. Hypotension and bradycardia aren't the concerns with withdrawal. This is a critical safety interaction during discontinuation. A patient on rivaroxaban 20 mg daily develops a pulmonary infection requiring azithromycin and fluconazole for aspergillosis. What is the most appropriate action? Option A. Continue all medications and monitor for bleeding signs. Option B. Hold rivaroxaban during antifungal therapy due to major bleeding risk from CYP3A4 PGP inhibition. Option C. Reduce rivaroxaban to 15 mg daily and continue monitoring. Option D. Switch to warfarin to avoid the interaction. Correct answer, B. The combination of azithromycin, moderate CYP3A4 PGP inhibitor, and fluconazole, strong CYP3A4 inhibitor, will dramatically increase rivaroxaban levels, creating unacceptable bleeding risk. Rivaroxaban should be held during dual strong inhibitor therapy. Dose reduction isn't sufficient for this magnitude of interaction. Switching to warfarin doesn't solve the immediate problem and creates new risks. Simply monitoring isn't adequate for this high-risk combination. A patient on chronic benzodiazepine therapy with alprazolam 1 mg 3 times daily begins oxycodone 10 mg every 4 hours for cancer pain. What is the most life-threatening risk with this combination? Option A. Serotonin syndrome from combined CNS effects. Option B. Respiratory depression from additive CNS depressant effects. Option C. Paradoxical agitation from GABAergic overactivation. Option D. Hepatotoxicity from combined CYP3A4 substrate competition. Correct answer, B. Opioids plus benzodiazepines cause additive, synergistic CNS and respiratory depression, significantly increasing overdose and death risk, a major public health concern. This combination requires careful monitoring and dose adjustment. Serotonin syndrome requires serotonergic agents. Paradoxical agitation isn't the primary safety concern. While both are CYP3A4 substrates, hepatotoxicity isn't the mechanism of harm. A patient taking bupropion 300 mg XL daily for depression also takes tramadol PRN for chronic back pain. The patient presents to the ED after a generalized tonic-clonic seizure. What best explains this event? Option A. Serotonin syndrome progression to seizure activity. Option B. Additive lowering of seizure threshold from both medications. Option C. Bupropion-induced hyponatremia causing seizure. Option D. Tramadol withdrawal precipitating seizure. Correct answer, B. Both bupropion and tramadol independently lower seizure threshold. Combined use significantly increases seizure risk, especially at higher doses. Bupropion has dose-dependent seizure risk. Avoid greater than 450 mg per day. While both have serotonergic properties, the seizure is primarily from threshold lowering, not serotonin syndrome. Hyponatremia is more common with SSRIs. The patient is taking, not withdrawing from, tramadol. A patient stabilized on warfarin starts St. John's wort for depression. 2 weeks later, the INR decreases from 2.4 to 1.2. What mechanism explains this change? Option A. St. John's wort inhibits vitamin K absorption, reducing clotting factor synthesis. Option B. CYP enzyme induction by St. John's wort, increasing warfarin metabolism. Option C. P-glycoprotein inhibition, enhancing warfarin elimination. Option D. Competitive binding at vitamin K epoxide reductase. Correct answer, B. St. John's wort is a potent CYP inducer, CYP3A4, 2C9, 1A2, and increases metabolism of many drugs, including warfarin, reducing INR, and increasing thrombosis risk. This also affects OCPs, immunosuppressants, and antiretrovirals. SJW doesn't affect vitamin K absorption or compete with warfarin's mechanism. PGP inhibition would increase, not decrease levels. Patients should avoid SJW due to multiple significant interactions. A patient taking escitalopram 20 mg daily and aspirin 81 mg daily reports dark tarry stools and hematemesis. Endoscopy reveals a gastric ulcer with active bleeding. Which mechanism contributed to this GI bleed? Option A, SSRI-induced thrombocytopenia causing spontaneous bleeding. Option B, aspirin inhibition of COX-1 with SSRI-mediated platelet serotonin depletion, impairing hemostasis. Option C, combined hepatotoxicity reducing clotting factor synthesis. Option D, SSRI-induced gastric acid hypersecretion, potentiating aspirin ulcerogenicity. Correct answer, B. SSRIs deplete platelet serotonin. Platelets uptake serotonin via SERT, impairing aggregation. Combined with aspirin's COX-1 inhibition and direct GI mucosal irritation, bleeding risk significantly increases, especially GI bleeding. This additive antiplatelet effect is often underappreciated. SSRIs don't cause thrombocytopenia or increase acid secretion. Hepatotoxicity isn't the mechanism. Consider PPI prophylaxis in patients on this combination. A patient on atorvastatin 80 mg daily begins gemfibrozil 600 mg twice daily for severe hypertriglyceridemia. Within 2 weeks, the patient develops severe muscle pain, weakness, and elevated CK, 25,000 units per liter. Why is gemfibrozil particularly problematic with statins? Option A, gemfibrozil inhibits CYP3A4, reducing statin metabolism. Option B, gemfibrozil inhibits statin glucuronidation and OATP transporters, dramatically increasing statin levels. Option C, both drugs independently cause rhabdomyolysis, creating additive risk. Option D, gemfibrozil depletes CoQ10, exacerbating statin myopathy. Correct answer, B. Gemfibrozil uniquely inhibits both UGT-mediated glucuronidation and OATP1B1 transporters, causing dramatic statin accumulation and highest rhabdomyolysis risk among fibrates. This combination is contraindicated. Fenofibrate is preferred if fibrate needed with statin. While statins use CYP3A4, gemfibrozil's primary interaction is through glucuronidation transporters. Both can cause myopathy, but the DDI mechanism is pharmacokinetic inhibition. A patient on dabigatran 150 mg twice daily for atrial fibrillation develops a UTI. The prescriber wants to start nitrofurantoin, but the pharmacist notes the patient is also taking dronedarone. What is the primary concern with this medication profile? Option A, dronedarone inhibits P-glycoprotein, increasing dabigatran exposure and bleeding risk. Option B, nitrofurantoin displaces dabigatran from protein binding sites. Option C, combined QT prolongation from dronedarone and nitrofurantoin causing arrhythmia. Option D, dronedarone enhances renal elimination, reducing dabigatran efficacy. Correct answer, A. Dronedarone is a moderate P-glycoprotein inhibitor that significantly increases dabigatran levels, elevating bleeding risk. This combination requires dose adjustment or alternative anticoagulation. Dronedarone has low protein binding, making displacement clinically insignificant. While dronedarone prolongs QT, nitrofurantoin doesn't significantly. Dronedarone doesn't enhance renal clearance. The PGP interaction is the critical safety concern requiring intervention. A 45-year-old male on tacrolimus for kidney transplant presents with tacrolimus trough of 18 nanograms per milliliter, goal 5 to 10, after starting fluconazole for oral candidiasis. He reports tremor and headache. Why should the pharmacist be most concerned about continuing this combination without intervention? Option A, irreversible nephrotoxicity from sustained immunosuppressant elevation. Option B, opportunistic infection from excessive immunosuppression. Option C, acute transplant rejection from tacrolimus binding to fluconazole. Option D, Stevens-Johnson syndrome from combined hepatotoxicity. Correct answer A. Fluconazole potently inhibits CYP3A4, dramatically increasing tacrolimus levels. Sustained supertherapeutic levels cause nephrotoxicity, potentially irreversible, neurotoxicity, tremor, headache, and increase infection risk. Tacrolimus has a narrow therapeutic index, requiring urgent dose reduction and close monitoring. Fluconazole doesn't cause rejection or bind tacrolimus. While both can affect liver enzymes, SJS isn't the primary concern with this specific interaction. A patient receiving haloperidol, 5 mg twice daily for schizophrenia, is prescribed levofloxacin 750 mg daily for pneumonia. The pharmacist reviews the ECG from last month, showing QTc of 440 milliseconds. What action is most appropriate? Option A. Dispense both medications and recommend routine follow-up. Option B. Contact prescriber to discuss alternative antibiotic due to additive QT prolongation risk. Option C. Reduce haloperidol dose by 50% during antibiotic therapy. Option D. Recommend switching levofloxacin to moxifloxacin for lower QT risk. Correct answer B. Both haloperidol and levofloxacin prolong QT interval. Combined use significantly increases torsades de pointes risk, especially with baseline QTc near 450 milliseconds. Alternative antibiotics without QT effects, e.g. beta-lactams, doxycycline, should be considered. Dispensing without intervention is inappropriate given the serious arrhythmia risk. Simply reducing haloperidol doesn't eliminate the additive risk. Moxifloxacin has greater QT prolongation than levofloxacin, making it worse. A pharmacy receives a prescription for methotrexate 15 mg weekly for rheumatoid arthritis. The patient's profile shows daily omeprazole, lisinopril, and ibuprofen 600 mg 3 times daily. Which medication poses the greatest risk for methotrexate toxicity? Option A. Omeprazole through CYP2C19 inhibition. Option B. Lisinopril through reduced renal perfusion. Option C. Ibuprofen through competitive inhibition of renal tubular secretion. Option D. All three medications contribute equally to methotrexate accumulation. Correct answer C. NSAIDs competitively inhibit renal tubular secretion of methotrexate. Both use organic anion transporters, causing accumulation and toxicity, myelosuppression, mucositis, hepatotoxicity. This is particularly concerning with chronic NSAID use in RA patients. Omeprazole doesn't significantly affect methotrexate clearance. While ACE inhibitors can reduce GFR, NSAIDs pose greater direct competition for elimination. The NSAID interaction requires either discontinuation or very close monitoring. A patient taking phenelzine, 15 mg 3 times daily for depression, eats aged cheese and develops severe headache, diaphoresis, and hypertension. BP 210-120. What is the underlying mechanism of this hypertensive crisis? Option A. Aged cheese contains tyramine, which is normally metabolized by MAO in the gut wall. Option B. Calcium in cheese displaces phenelzine from MAO binding sites. Option C. Cheese-derived tryptophan is converted to excessive serotonin. Option D. Phenelzine enhances absorption of dietary sodium, causing fluid retention. Correct answer A. MAOA in the gut wall normally metabolizes dietary tyramine found in aged cheese, cured meats, draft beer. MAOI use prevents tyramine breakdown, allowing absorption and subsequent norepinephrine release, causing hypertensive crisis. This requires dietary restriction and patient education about tyramine-containing foods. Calcium doesn't displace MAOIs. While tryptophan converts to serotonin, this isn't the mechanism of hypertensive crisis. Sodium retention doesn't explain acute severe hypertension. A patient on voriconazole, 200 mg twice daily, for aspergillosis has breakthrough fungal infection. The profile reveals recently started rifabutin for MAC prophylaxis. What explains the therapeutic failure? Option A. Rifabutin competitively inhibits fungal cell wall synthesis. Option B. Rifabutin induces CYP450 enzymes, reducing voriconazole levels below therapeutic threshold. Option C. Voriconazole inhibits rifabutin activation to antimicrobial form. Option D. Combined hepatotoxicity, reducing both drug levels through liver damage. Correct answer B. Rifabutin, like rifampin, induces CYP enzymes, dramatically reducing voriconazole levels and causing treatment failure.
Rifamycins are contraindicated with most azoles due to this interaction. The reverse interaction also occurs. Voriconazole inhibits rifabutin metabolism, increasing toxicity risk.
Rifabutin doesn't affect fungal synthesis or require activation. Hepatotoxicity isn't the mechanism of therapeutic failure. Alternative antifungal or antimycobacterial therapy is needed. A patient on chronic methadone 80 mg daily for opioid use disorder starts carbamazepine for newly diagnosed epilepsy. 3 weeks later, the patient reports withdrawal symptoms, muscle aches, anxiety, insomnia. What is the most likely explanation? Option A. Carbamazepine competitively antagonizes opioid receptors. Option B. CYP3A4 induction by carbamazepine, reducing methadone levels. Option C. Carbamazepine-induced hypermetabolism, increasing methadone clearance. Option D. Displacement of methadone from protein binding sites.
Correct answer B. Carbamazepine potently induces CYP3A4, increasing methadone metabolism and reducing levels, precipitating withdrawal. Methadone dose must be increased, often significantly when starting enzyme inducers.
Carbamazepine doesn't antagonize opioid receptors. While metabolism increases, it's specifically through CYP induction, not general hypermetabolism. Protein displacement doesn't explain sustained reduction in drug levels and withdrawal symptoms. A 68-year-old on colchicine 0.6 mg daily for gout prophylaxis develops severe diarrhea, abdominal pain, and leukopenia, WBC 2.1, after starting clarithromycin for bronchitis. What is the mechanism of this life-threatening interaction? Option A. Clarithromycin-induced bone marrow suppression additive to colchicine effects. Option B. Dual inhibition of CYP3A4 and P-glycoprotein causing colchicine toxicity. Option C. Clarithromycin displacement of colchicine from tubulin binding sites. Option D. Combined direct GI toxicity from both medications. Correct answer B. Colchicine is a CYP3A4 and PGP substrate with narrow therapeutic index. Strong CYP3A4 PGP inhibitors like clarithromycin cause severe, potentially fatal toxicity, myelosuppression, multi-organ failure, GI symptoms. This combination is contraindicated, especially in renal hepatic impairment. Clarithromycin doesn't independently cause myelosuppression at therapeutic doses. The mechanism is pharmacokinetic inhibition, dramatically increasing colchicine exposure, not pharmacodynamic or displacement effects. A patient taking theophylline 400 mg twice daily with levels previously stable at 12 microgram per milliliter develops nausea, tremor, and a theophylline level of 28 microgram per milliliter. Recent ciprofloxacin was added for prostatitis. Why is ciprofloxacin particularly problematic? Option A. Ciprofloxacin inhibits CYP1A2, reducing theophylline metabolism. Option B. Chelation complex formation, reducing theophylline absorption. Option C. P-glycoprotein inhibition, enhancing theophylline CNS penetration. Option D. Ciprofloxacin-induced alkalinization of urine, reducing renal clearance. Correct answer. A. Fluoroquinolones, especially ciprofloxacin, inhibit CYP1A2, theophylline's primary metabolic pathway, causing significant accumulation and toxicity. Theophylline has a narrow therapeutic index, 5 to 15 micrograms per milliliter, making this interaction clinically serious. The chelation interaction with FQs involves divalent cations, not theophylline. Theophylline isn't a PGP substrate. Urine pH affects elimination, but isn't the primary mechanism with FQs. Dose reduction is necessary when starting ciprofloxacin. A patient on high-dose aspirin 975 mg 4 times daily for rheumatic fever develops toxic salicylate levels after starting a new medication. Which addition most likely caused this toxicity? Option A. Acetaminophen 1000 mg 4 times daily. Option B. Pantoprazole 40 mg daily. Option C. Furosemide 40 mg twice daily causing urinary alkalinization. Option D. Acetazolamide 250 mg twice daily causing urinary acidification. Correct answer D. Salicylate elimination is pH dependent. Acidic urine from acetazolamide acidosis increases reabsorption and decreases clearance, causing toxicity. Alkalinizing urine, sodium bicarbonate, enhances elimination and is used in salicylate overdose. Acetaminophen and PPIs don't significantly affect aspirin levels. Furosemide causes alkalinization, not mentioned in correct answer, but acetazolamide's acidification is more problematic. Understanding pH-dependent elimination is critical for managing salicylate therapy. A patient stabilized on cyclosporin for transplant immunosuppression starts taking high-dose vitamin E and coenzyme Q10 supplements. The cyclosporin trough decreases from 180 nanograms per milliliter to 95 nanograms per milliliter. What is the most concerning outcome? Option A. Increased infection risk from subtherapeutic immunosuppression. Option B. Acute transplant rejection from inadequate cyclosporin levels. Option C. Nephrotoxicity from unopposed oxidative stress. Option D. Cyclosporin resistance from competitive receptor binding. Correct answer. B. Some supplements, St. John's wort, high-dose vitamin E, can induce metabolism or affect absorption of immunosuppressants, reducing levels below therapeutic range and precipitating acute rejection, the most serious immediate consequence. While infection risk may decrease with lower immunosuppression, rejection threatens graft survival. Nephrotoxicity occurs with high levels. Supplements don't cause drug resistance. All supplement use requires disclosure in transplant patients. A patient taking allopurinol 300 mg daily for chronic gout starts azathioprine for inflammatory bowel disease. Within 2 weeks, the patient develops severe pancytopenia, WBC 1.2, platelets 45,000. What mechanism caused this toxicity? Option A. Azathioprine inhibits xanthine oxidase, preventing allopurinol metabolism. Option B. Allopurinol inhibits xanthine oxidase, preventing azathioprine metabolism to inactive metabolites. Option C. Combined bone marrow suppression from additive myelotoxic effects. Option D. Allopurinol displacement of azathioprine from purine synthesis pathways. Correct answer B. Azathioprine is metabolized to 6-mercaptopurine, then inactivated by xanthine oxidase. Allopurinol inhibits this pathway, causing accumulation of active metabolites and severe myelosuppression. Azathioprine dose must be reduced 65 to 75% when combined with allopurinol. Both drugs affect purine metabolism, but the mechanism is specific enzyme inhibition. While both can cause myelosuppression, the DDI magnifies toxicity through pharmacokinetic interaction. A patient on isoniazid 300 mg daily for TB treatment develops acute mental status changes and seizures after consuming alcohol. What is the most likely explanation for this neurological emergency? Option A. Disulfiram-like reaction from isoniazid, inhibiting aldehyde dehydrogenase. Option B. Alcohol induction of CYP2E1 producing toxic isoniazid metabolites. Option C. Combined GABA antagonism lowering seizure threshold. Option D. Isoniazid inhibition of alcohol dehydrogenase causing acetaldehyde accumulation. Correct answer, B. Chronic alcohol use induces CYP2E1, which converts isoniazid to hepatotoxic metabolites, hydrazine. This increases hepatotoxicity and neurotoxicity risk, seizures, peripheral neuropathy. Pyridoxine supplementation helps prevent neurotoxicity. Disulfiram reactions involve different enzymes and present differently. Flushing, hypotension. Neither drug directly antagonizes GABA. The aldehyde dehydrogenase pathway isn't relevant to this interaction. This interaction worsens with chronic alcohol use. A patient taking sirolimus for kidney transplant has a trough level of 24 nanograms per milliliter, goal 5 to 15, after starting voriconazole for fungal pneumonia. Besides nephrotoxicity, what additional serious toxicity is most concerning with elevated sirolimus? Option A. Bone marrow suppression causing pancytopenia. Option B. QT prolongation from both medications. Option C. Pulmonary toxicity including interstitial pneumonitis. Option D. Acute hepatic necrosis from combined metabolism. Correct answer, C. Sirolimus causes dose-dependent pulmonary toxicity, interstitial pneumonitis, pulmonary fibrosis, particularly concerning in a patient with fungal pneumonia. Voriconazole inhibits CYP3A4, dramatically increasing sirolimus levels. Both nephrotoxicity and pulmonary effects are serious. While myelosuppression can occur, pulmonary toxicity is more characteristic of mTOR inhibitors. Neither significantly prolongs QT. The combination requires dose adjustment and close monitoring of both trough levels and pulmonary function. A patient on tamoxifen for breast cancer starts paroxetine 20 mg daily for hot flashes. What is the most concerning consequence of this combination? Option A. Serotonin syndrome from tamoxifen serotonergic properties. Option B. Reduced tamoxifen efficacy from CYP2D6 inhibition, preventing conversion to active endoxifen. Option C. Enhanced thrombotic risk from additive estrogen-like effects. Option D. Severe QT prolongation from combined effects. Correct answer, B. Tamoxifen requires CYP2D6 activation to endoxifen, active metabolite. Paroxetine is a potent CYP2D6 inhibitor, reducing endoxifen formation and potentially compromising breast cancer outcomes. Alternative antidepressants, venlafaxine, escitalopram with minimal CYP2D6 inhibition are preferred. Tamoxifen isn't serotonergic. It's a SERM, not estrogen, and doesn't increase clotting with SSRIs. Neither significantly prolongs QT. This interaction impacts cancer treatment efficacy. A patient taking warfarin with stable INRs develops acute hepatitis after starting high-dose acetaminophen, 4,000 mg daily, and chronic alcohol use. Beyond hepatotoxicity, what additional risk requires immediate attention? Option A. Enhanced warfarin effect from reduced clotting factor synthesis due to liver damage. Option B. Reduced warfarin absorption from acetaminophen-induced gastritis. Option C. Warfarin-induced hepatic necrosis, potentiated by acetaminophen. Option D. Competitive CYP2E1 metabolism, reducing both drug efficacies. Correct answer, A. Acute hepatitis reduces synthesis of vitamin K-dependent clotting factors, potentiating warfarin effect independent of INR changes. INR may not reflect reduced factor levels in acute liver injury. Combined with acetaminophen hepatotoxicity, bleeding risk is extremely high. Acetaminophen doesn't affect warfarin absorption. Warfarin doesn't cause hepatic necrosis. While alcohol affects CYP2E1, the immediate concern is loss of hepatic synthetic function and bleeding risk requiring urgent assessment. A patient on tizanidine 4 mg 3 times daily for muscle spasms reports severe hypotension and sedation after starting ciprofloxacin. What explains this reaction? Option A. Ciprofloxacin inhibits CYP1A2, increasing tizanidine levels with enhanced alpha-2 agonist effects. Option B. Additive hypotensive effects from both medications. Option C. Ciprofloxacin-induced orthostatic hypotension unmasking tizanidine effects. Option D. P-glycoprotein inhibition enhancing tizanidine CNS penetration. Correct answer. A. Tizanidine is extensively metabolized by CYP1A2. Ciprofloxacin potently inhibits CYP1A2, causing dramatic tizanidine accumulation and severe hypotension/sedation. This combination is contraindicated. Fluvoxamine has similar effects. Ciprofloxacin doesn't cause significant hypotension alone. PGP effects aren't relevant to this interaction. The mechanism is pharmacokinetic inhibition of metabolism, not additive pharmacodynamic effects. Alternative antibiotics should be used. A patient on ergotamine for migraines develops severe peripheral ischemia, cold, painful extremities, after starting clarithromycin for sinusitis. What is the mechanism of this vascular emergency? Option A. Clarithromycin-induced vasospasm additive to ergotamine effects. Option B. CYP3A4 inhibition causing ergotamine accumulation and severe vasoconstriction. Option C. P-glycoprotein inhibition enhancing ergotamine distribution to peripheral vessels. Option D. Displacement of ergotamine from alpha-adrenergic binding sites. Correct answer, B. Ergot alkaloids are CYP3A4 substrates. Strong inhibitors, macrolides, azoles, protease inhibitors, cause ergotamine accumulation, leading to ergotism, severe vasoconstriction, peripheral ischemia, gangrene. This combination is contraindicated. Clarithromycin doesn't independently cause vasospasm. While PGP may be involved, CYP3A4 inhibition is the primary mechanism. Displacement doesn't explain sustained toxicity. This is a medical emergency requiring ergotamine discontinuation and vasodilator therapy. A patient taking fexofenadine 180 mg daily for allergies reports the medication is no longer effective. The patient recently started drinking grapefruit juice daily for health benefits. What explains this treatment failure? Option A. Grapefruit juice induces CYP3A4, increasing fexofenadine metabolism. Option B. Grapefruit juice inhibits OATP transporters, reducing fexofenadine absorption. Option C. Vitamin C in grapefruit juice degrades fexofenadine. Option D. Grapefruit juice alkalinizes gastric pH, preventing fexofenadine dissolution. Correct answer, B. Unlike most grapefruit interactions, CYP3A4 inhibition increasing drug levels, grapefruit inhibits OATP transporters responsible for fexofenadine absorption, paradoxically reducing bioavailability and efficacy. This occurs with several OATP substrates. Grapefruit inhibits, not induces, CYP3A4. Vitamin C doesn't degrade fexofenadine. pH effects aren't the mechanism. This counterintuitive interaction demonstrates that grapefruit effects vary by drug and mechanism. A patient on clozapine 400 mg daily with stable levels quits smoking after 20 years. 2 weeks later, the patient develops sedation, hypersalivation, and a clozapine level of 950 nanograms per milliliter. Therapeutic, 350 to 600. What explains this toxicity? Option A. Nicotine withdrawal, enhancing clozapine absorption. Option B. loss of CYP1A2 induction from smoking cessation, increasing clozapine levels. Option C, improved medication adherence after smoking cessation. Option D, clozapine accumulation from improved pulmonary function. Correct answer, B. Tobacco smoke, polycyclic aromatic hydrocarbons, not nicotine, induces CYP1A2. Smokers require higher clozapine doses. Smoking cessation removes induction, dramatically increasing levels and causing toxicity. Dose must be reduced by 25 to 50% when quitting. This also affects olanzapine and theophylline. Nicotine replacement doesn't cause this interaction, only smoke does. Adherence and pulmonary function don't explain the pharmacokinetic change. Monitoring is essential during smoking status changes. A patient on carvedilol 25 mg twice daily for heart failure develops severe bradycardia, HR38, and hypotension after starting diltiazem for atrial fibrillation rate control. What is the primary mechanism? Option A, diltiazem inhibits CYP2D6, increasing carvedilol levels. Option B, additive negative chronotropic and inotropic effects on cardiac conduction. Option C, competitive binding at beta-adrenergic receptors. Option D, diltiazem-induced hyperkalemia, enhancing beta blocker effects. Correct answer, B. Beta blockers and non-DHP CCBs, diltiazem, verapamil, both slow AV conduction and depress cardiac contractility. Combined use causes severe bradycardia, heart block, and heart failure exacerbation. This combination should generally be avoided, especially in patients with conduction abnormalities or reduced ejection fraction. While diltiazem inhibits CYP3A4, not 2D6, the primary mechanism is pharmacodynamic. CCBs don't cause hyperkalemia or compete at beta receptors. A patient on buspirone 15 mg twice daily for anxiety starts itraconazole for toenail fungus. The patient develops severe dizziness and reports feeling extremely drowsy. What is the most likely explanation? Option A, itraconazole inhibits CYP3A4, dramatically increasing buspirone levels. Option B, additive CNS depression from both medications. Option C, itraconazole-induced vestibular toxicity, potentiated by buspirone. Option D, P-glycoprotein inhibition enhancing buspirone CNS penetration. Correct answer, A. Buspirone undergoes extensive first-pass metabolism via CYP3A4. Strong inhibitors like itraconazole cause dramatic increases in buspirone exposure, tenfold or more, leading to excessive sedation and side effects. Dose reduction or alternative antifungal is necessary. Buspirone alone doesn't cause significant sedation, and itraconazole doesn't cause CNS depression or vestibular toxicity at therapeutic doses. PGP effects are minimal. This represents a classic CYP3A4 inhibition interaction. A patient taking dofetilide for atrial fibrillation is hospitalized for pneumonia. The physician wants to start trimethoprim sulfamethoxazole. Why should the pharmacist strongly object to this combination? Option A, TMP-SMX inhibits CYP3A4, increasing dofetilide levels and QT prolongation. Option B, trimethoprim inhibits renal cationic secretion, causing dofetilide accumulation and torsades risk. Option C, combined QT prolongation from both medications. Option D, TMP-SMX-induced hypokalemia, potentiating dofetilide's proarrhythmic effects. Correct answer, B. Dofetilide is renally eliminated via cationic secretion pathways. Trimethoprim competitively inhibits these transporters, causing dofetilide accumulation, QT prolongation, and life-threatening torsades de pointes. This combination is contraindicated. Dofetilide has strict renal dosing and requires monitoring. While both can prolong QT, the mechanism is renal elimination inhibition, not additive pharmacodynamic effects. TMP-SMX causes hyperkalemia, not hypokalemia. A patient on phenytoin 300 mg daily has a level of 8 micrograms per milliliter, therapeutic 10 to 20, despite good adherence. The profile shows recent addition of high-dose folic acid, 5 mg daily, prescribed for macrocytic anemia. What explains the subtherapeutic level? Option A. Folic acid enhances CYP2C9 activity, increasing phenytoin metabolism. Option B. Folic acid reduces phenytoin absorption through chelation. Option C. Folic acid corrects phenytoin-induced folate deficiency, improving metabolism. Option D. Folic acid enhances phenytoin's conversion to inactive metabolites. Correct answer. A. High-dose folic acid can increase phenytoin metabolism, possibly through enhanced CYP2C9 activity, reducing levels and potentially causing breakthrough seizures. Conversely, phenytoin causes folate deficiency. This creates a management dilemma. Treat folate deficiency but monitor phenytoin levels closely and adjust dose. Folate doesn't chelate phenytoin or directly affect metabolite formation. The mechanism isn't fully understood, but clinical significance is established. A patient taking lithium 600 mg twice daily with levels stable at 0.9 milliequivalents per liter starts celecoxib 200 mg twice daily for osteoarthritis. 3 weeks later, lithium level is 1.6 milliequivalents per liter with symptoms of tremor and confusion. Why do selective COX-2 inhibitors affect lithium? Option A. COX-2 inhibitors have no effect on lithium. The patient likely became dehydrated. Option B. COX-2 inhibition reduces renal prostaglandin synthesis, decreasing lithium clearance, similar to non-selective NSAIDs. Option C. Celecoxib inhibits CYP metabolism of lithium. Option D. Celecoxib enhances lithium absorption from the GI tract. Correct answer B. Both non-selective NSAIDs and COX-2 inhibitors reduce renal prostaglandin synthesis, decreasing GFR and increasing proximal tubule lithium reabsorption, causing accumulation. The interaction occurs with all NSAIDs, including celecoxib. Lithium isn't metabolized by CYP enzymes. Enhanced absorption doesn't explain sustained elevation. While dehydration affects lithium, the temporal relationship with celecoxib and mechanism of prostaglandin-mediated renal effects make this the DDI. Aspirin irreversible COX inhibition has minimal effect. A patient on chronic oral contraceptive therapy, ethinyl estradiol norethindrone, reports breakthrough bleeding and missed periods after starting carbamazepine for trigeminal neuralgia. What is the most critical risk that requires immediate counseling? Option A. Increased thromboembolic risk from combined hormonal effects. Option B. Contraceptive failure and unintended pregnancy from CYP3A4 induction. Option C. Ovarian cyst formation from disrupted hormone feedback. Option D. Endometrial hyperplasia from unopposed estrogen exposure. Correct answer, B. Carbamazepine potently induces CYP3A4, dramatically reducing ethinyl estradiol and progestin levels, causing OCP failure. Breakthrough bleeding signals reduced hormone levels. Backup contraception is mandatory, and alternative birth control methods should be considered. The induction reduces, not increases, estrogen exposure. Ovarian cysts and endometrial hyperplasia aren't the primary concerns. This interaction applies to all enzyme inducers, phenytoin, rifampin, St. John's wort, and requires proactive counseling. A patient on venlafaxine 150 mg twice daily for depression presents to the ED with agitation, dilated pupils, hyperreflexia, and temperature of 39.5 degrees Celsius after taking dextromethorphan for cough. What intervention is most urgently needed? Option A. Administer activated charcoal to prevent further absorption. Option B. Discontinue all serotonergic agents and provide supportive care with benzodiazepines. Option C. Start broad-spectrum antibiotics for suspected sepsis. Option D. Administer naloxone to reverse opioid toxicity. Correct answer B. This is serotonin syndrome from combining SNRI with dextromethorphan, serotonin reuptake inhibitor, and weak NMDA antagonist with serotonergic properties. Management requires discontinuing causative agents, supportive care, temperature control, and benzodiazepines for agitation. Cyproheptadine may be considered for severe cases. This isn't sepsis. No infection source, rapid onset after drug. Naloxone is inappropriate. Dextromethorphan isn't a significant opioid agonist. Activated charcoal is ineffective after absorption has occurred. A patient taking sitagliptin 100 mg daily and glipizide 10 mg twice daily for diabetes starts clarithromycin for pneumonia. Blood glucose drops to 45 mg per deciliter with confusion and diaphoresis. Which medication interaction is most responsible? Option A. Clarithromycin inhibits DPP-4, enhancing sitagliptin activity. Option B. Clarithromycin inhibits CYP2C9, reducing glipizide metabolism. Option C. Sitagliptin enhances glipizide absorption through GLP-1 effects. Option D. Clarithromycin directly stimulates pancreatic insulin secretion. Correct answer B. Clarithromycin inhibits CYP2C9, reducing sulfonylurea metabolism and causing severe prolonged hypoglycemia, particularly dangerous in elderly patients. Glipizide has higher hypoglycemia risk than other sulfonylureas. Clarithromycin doesn't affect DPP-4 or directly stimulate insulin. DPP-4 inhibitors like sitagliptin have low hypoglycemia risk alone. The sulfonylurea macrolide interaction requires dose adjustment or close glucose monitoring. Immediate treatment with glucose/glucagon is needed. A patient stabilized on insulin glargine 40 units at bedtime starts propranolol 80 mg twice daily for hypertension. What is the most concerning risk with this combination? Option A. Enhanced insulin sensitivity from beta blockade, causing hypoglycemia. Option B. Masked warning symptoms of hypoglycemia and impaired counter-regulatory response. Option C. Insulin resistance from beta blocker antagonism of insulin receptors. Option D. Reduced insulin absorption from peripheral vasoconstriction. Correct answer B. Non-selective beta blockers mask hypoglycemia warning signs, tachycardia, tremor by blocking adrenergic symptoms, and impair gluconeogenesis glycogenolysis, counter-regulatory response, prolonging hypoglycemia. Patients may only experience sweating, cholinergic symptom. Beta-1 selective agents, metoprolol, atenolol, are preferred in diabetes. Beta blockers don't enhance insulin sensitivity or antagonize insulin receptors. Absorption isn't significantly affected. This interaction requires patient education about altered hypoglycemia presentation. A patient on apixaban 5 mg twice daily develops cellulitis requiring hospitalization. The ID physician prescribes both vancomycin and rifampin for suspected MRSA with possible prosthetic joint involvement. What is the primary concern? Option A. Rifampin inhibits P-glycoprotein, increasing apixaban and bleeding risk. Option B. Rifampin induces CYP3A4 and P-glycoprotein, reducing apixaban levels and increasing thrombosis risk. Option C. Vancomycin displaces apixaban from protein binding. Option D. Combined nephrotoxicity, reducing apixaban renal clearance. Correct answer. B. Rifampin potently induces CYP3A4 and P-glycoprotein, dramatically reducing apixaban levels and anticoagulant efficacy, increasing stroke VTE risk. Alternative antibiotics or switching to warfarin, less affected by rifampin, should be considered. Rifampin induces, not inhibits, these pathways. Vancomycin doesn't significantly affect protein binding or apixaban metabolism. While vancomycin can cause nephrotoxicity, apixaban is primarily hepatically eliminated, 25% renal. The induction effect is the critical concern. A patient taking alendronate 70 mg weekly for osteoporosis reports the medication stopped working, despite good adherence. Review shows the patient started taking a calcium supplement with breakfast and now takes all morning medications together. What counseling is needed? Option A. Increase alendronate to 70 mg twice weekly. Option B. Separate alendronate from calcium by at least 30 to 60 minutes and take on empty stomach. Option C. Switch to intravenous bisphosphonate to avoid the interaction. Option D. Continue current regimen as calcium enhances bone formation. Correct answer, B. Bisphosphonates chelate with divalent cations, calcium, magnesium, iron, forming insoluble complexes that aren't absorbed, causing treatment failure. Alendronate must be taken on empty stomach with plain water, 30 to 60 minutes before food, other medications. Patients should remain upright to prevent esophagitis. Increasing frequency doesn't solve absorption problem. IV therapy is unnecessary for this easily correctable adherence administration issue. This is a common, preventable interaction requiring specific administration counseling. A patient on tacrolimus for liver transplant has a trough of 3.2 nanograms per milliliter, goal 5 to 15, and presents with signs of acute rejection. The patient reports starting St. John's wort for mood after reading it was natural and safe. What is the mechanism of this potentially catastrophic interaction? Option A. St. John's wort competitively inhibits calcineurin, preventing tacrolimus binding. Option B. St. John's wort induces CYP3A4 and P-glycoprotein, dramatically reducing tacrolimus levels. Option C. St. John's wort enhances tacrolimus renal elimination through transporter induction. Option D. St. John's wort causes direct hepatotoxicity, reducing tacrolimus synthesis. Correct answer, B. St. John's wort potently induces CYP3A4, P-glycoprotein, and other enzymes transporters, causing subtherapeutic immunosuppressant levels and transplant rejection. This interaction affects cyclosporine, tacrolimus, sirolimus, and many other drugs, OCPs, antiretrovirals, warfarin. SJW doesn't compete at calcineurin or affect drug synthesis. The consequence, rejection, graft loss, is severe. Transplant patients must avoid all herbal supplements without approval. Tacrolimus levels must be urgently optimized and rejection treated. A patient on quetiapine 300 mg at bedtime for schizophrenia starts ketoconazole for systemic fungal infection. The patient develops severe sedation, orthostatic hypotension, and QTc prolongation to 520 milliseconds. What explains this toxicity? Option A. Additive QT prolongation from both medications. Option B. Ketoconazole inhibits CYP3A4, dramatically increasing quetiapine levels. Option C. Ketoconazole enhances quetiapine's dopamine antagonism. Option D. P-glycoprotein inhibition increasing CNS quetiapine penetration. Correct answer, B. Quetiapine is extensively metabolized by CYP3A4. Ketoconazole, potent CYP3A4 inhibitor, causes dramatic quetiapine accumulation, leading to excessive sedation, orthostasis, and QT prolongation. Dose reduction, potentially 75 to 85%, is necessary with strong CYP3A4 inhibitors. While both can prolong QT, the mechanism is pharmacokinetic, causing elevated quetiapine levels. Ketoconazole doesn't affect dopamine pathways, PGP effects are secondary. This interaction occurs with all azoles and requires proactive dose adjustment. A patient taking warfarin with INR stable at 2.8 develops a skin infection and starts fluconazole 200 mg daily. 5 days later, INR is 7.2 with epistaxis and gingival bleeding. What is the most appropriate immediate action? Option A, continue both medications and recheck INR in 1 week. Option B, hold warfarin, administer vitamin K, and contact prescriber for warfarin dose reduction. Option C, discontinue fluconazole and switch to alternative antifungal. Option D, reduce fluconazole dose by 50% and continue warfarin.
Correct answer B. Fluconazole potently inhibits CYP2C9,
Dramatically increasing warfarin effect. INR 7.2 with bleeding requires immediate intervention. Hold warfarin, give vitamin K, oral low dose for minor bleeding, and restart warfarin at reduced dose, 25 to 50% reduction. Simply continuing risks major hemorrhage. Switching antifungals doesn't address current bleeding risk. Reducing fluconazole doesn't adequately manage the interaction. This is a predictable, severe interaction requiring proactive dose adjustment when starting azoles.
A patient on prednisone 20 mg daily for COPD exacerbation is prescribed itraconazole for suspected aspergillosis. The patient develops severe hyperglycemia, glucose 450 mg d/L, mood changes, and proximal muscle weakness. What mechanism contributed to these symptoms? Option A, itraconazole inhibits CYP3A4, increasing prednisone levels and glucocorticoid effects. Option B, additive hyperglycemic effects from both medications. Option C, itraconazole-induced adrenal suppression, reducing cortisol metabolism. Option D, itraconazole displacement of prednisone from glucocorticoid receptors. Correct answer. A. Prednisone is metabolized by CYP3A4. Itraconazole, strong CYP3A4 inhibitor, increases corticosteroid levels, causing or worsening Cushingoid effects, hyperglycemia, psychiatric symptoms, myopathy, fluid retention, immunosuppression. Inhaled nasal corticosteroids with potent CYP3A4 substrates, fluticasone budesonide, can cause adrenal suppression with azoles. While corticosteroids cause hyperglycemia, the mechanism here is increased drug levels. Itraconazole doesn't affect adrenal function or displace steroids from receptors. A patient taking pioglitazone 45 mg daily and rosuvastatin 20 mg daily develops severe muscle pain and dark urine. CK is 18,000 U-liter. Besides statin myopathy, what additional concern exists with this specific combination? Option A, pioglitazone inhibits CYP2C8, increasing statin levels. Option B, pioglitazone enhances statin uptake into muscle tissue via OATP. Option C, combined fluid retention causing compartment syndrome. Option D, pioglitazone-induced rhabdomyolysis is additive to statin effects. Correct answer, C. While rosuvastatin causes rhabdomyolysis, elevated CK, myoglobinuria, pioglitazone causes significant fluid retention and edema, which could contribute to or worsen compartment syndrome in the setting of severe rhabdomyolysis. Rosuvastatin isn't primarily metabolized by CYP2C8, minimal hepatic metabolism. The primary issue is statin-induced rhabdomyolysis, but TZD-related fluid retention is a relevant complicating factor. OATP effects aren't the primary mechanism. This requires immediate statin discontinuation, aggressive hydration, and monitoring for renal failure. A patient on chronic diazepam 10 mg 3 times daily for anxiety starts isoniazid 300 mg daily for latent TB. 2 weeks later, the patient reports increased sedation and difficulty concentrating. What explains this change? Option A,
Isoniazid inhibits CYP2C19, reducing diazepam metabolism. Option B. Isoniazid enhances GABA activity, potentiating benzodiazepine effects. Option C. Combined CNS depression from both medications. Option D. Isoniazid-induced hepatotoxicity, reducing diazepam clearance. Correct answer: A. Isoniazid inhibits CYP2C19 and CYP3A4 to lesser extent, reducing metabolism of benzodiazepines like diazepam, causing accumulation and excessive sedation. Shorter-acting benzodiazepines metabolized by glucuronidation, lorazepam, oxazepam, temazepam, are less affected. Isoniazid doesn't enhance GABA. While both can affect CNS, the mechanism is pharmacokinetic inhibition. Hepatotoxicity from INH could worsen this, but isn't the primary DDI mechanism. Dose reduction may be necessary. A patient taking atorvastatin 80 mg daily begins drinking large amounts of grapefruit juice daily. The patient develops muscle pain, weakness, and elevated CK, 12,000 ULL. What is the mechanism of this food-drug interaction? Option A. Grapefruit juice inhibits CYP3A4 in gut wall, increasing atorvastatin bioavailability. Option B. Grapefruit juice enhances statin absorption through OATP activation. Option C. Vitamin C in grapefruit juice causes oxidative muscle damage. Option D. Grapefruit juice alkalinizes urine, reducing statin elimination. Correct answer: A. Grapefruit juice contains furanocoumarins that irreversibly inhibit intestinal CYP3A4, dramatically increasing first-pass bioavailability of statins, especially simvastatin, lovastatin, atorvastatin, causing myopathy, rhabdomyolysis. Effect can last 24+ hours after single serving. Pravastatin and rosuvastatin are less affected, not CYP3A4 substrates. Grapefruit inhibits, not activates, OATP, relevant for fexofenadine. Vitamin C doesn't cause myopathy. Urinary pH doesn't affect statin elimination. Patients should avoid grapefruit juice with susceptible statins. A patient on amitriptyline 50 mg at bedtime for neuropathic pain starts terbinafine 250 mg daily for onychomycosis. The patient develops severe dry mouth, urinary retention, confusion, and blurred vision. What is the most likely explanation? Option A. Terbinafine inhibits CYP2D6, increasing amitriptyline levels and anticholinergic effects. Option B. Additive anticholinergic effects from both medications. Option C. Terbinafine-induced hepatotoxicity, reducing amitriptyline metabolism. Option D. Serotonin syndrome from combined serotonergic properties. Correct answer: A. Terbinafine potently inhibits CYP2D6, reducing metabolism of TCAs and increasing levels, causing anticholinergic toxicity, dry mouth, urinary retention, confusion, mydriasis, constipation. TCAs have narrow therapeutic indices. Terbinafine doesn't have significant anticholinergic properties. While terbinafine can cause hepatotoxicity, the mechanism is specific CYP2D6 inhibition. TCAs have serotonergic properties, but this presentation is anticholinergic toxicity. Dose reduction or alternative antifungal may be needed. A patient on levothyroxine 125 micrograms daily for hypothyroidism starts sucralfate 1 gram 4 times daily for peptic ulcer disease. 6 weeks later, TSH is elevated at 12.5 MIU/liter, and the patient reports fatigue and weight gain. What intervention is most appropriate? Option A. Increase levothyroxine dose to 150 micrograms daily. Option B. Separate levothyroxine and sucralfate administration by at least 4 hours. Option C. Switch to liothyronine to overcome the interaction. Option D. Discontinue sucralfate and use PPI instead. Correct answer B.
Sucralfate, aluminum-containing, binds levothyroxine in GI tract, reducing absorption and causing hypothyroid symptoms. This also occurs with antacids, calcium, iron, bile acid sequestrants, and PPIs. Separating administration by 4+ hours prevents interaction. Simply increasing dose doesn't address ongoing binding. Switching to T3 doesn't solve absorption problem. Changing ulcer therapy may not be necessary if administration is separated. This is a common, preventable interaction requiring proper timing counseling. A patient taking donepezil 10 mg daily for Alzheimer's disease starts propafenone for atrial fibrillation. The patient develops severe bradycardia, HR35, nausea, and syncope. What is the mechanism of this cardiac emergency? Option A. Propafenone inhibits CYP2D6, increasing donepezil levels. Option B. Additive vagotonic effects from both medications causing excessive bradycardia. Option C. Propafenone-induced QT prolongation potentiated by donepezil. Option D. Donepezil inhibition of propafenone metabolism causing antiarrhythmic toxicity.
Correct answer B. Donepezil cholinesterase inhibitor increases acetylcholine, causing vagotonic effects including bradycardia. Propafenone, class IC antiarrhythmic, also slows conduction. Combined use can cause severe bradycardia, AV block, and syncope. This applies to all cholinesterase inhibitors with other bradycardic agents, beta blockers, non-DHPCCBs, digoxin. While CYP interactions may occur, the primary mechanism is additive pharmacodynamic slowing of heart rate. Close monitoring or alternative rate control is needed. A patient on chronic NSAID therapy with meloxicam 15 mg daily starts low-dose aspirin 81 mg daily for cardiovascular prevention. The prescriber wants to ensure aspirin's antiplatelet effect isn't compromised. What counseling should be provided? Option A. Take both medications together to enhance antiplatelet effects. Option B. Take aspirin at least 2 hours before meloxicam to allow irreversible platelet inhibition. Option C. Switch to ibuprofen as it doesn't interfere with aspirin. Option D. Increase aspirin to 325 mg to overcome competitive inhibition. Correct answer B. Some NSAIDs, ibuprofen, naproxen, competitively inhibit COX-1, preventing aspirin's irreversible acetylation of platelet COX-1 and reducing cardioprotective effect. Taking aspirin first, 2+ hours before NSAID, allows irreversible inhibition before competitive binding. Meloxicam and diclofenac appear to have less interaction. Ibuprofen has significant interaction and shouldn't be recommended. Taking together negates aspirin's effect. Increasing aspirin dose doesn't overcome competitive inhibition and increases bleeding risk. A patient on chronic metronidazole for recurrent C. difficile infection attends a wedding and consumes alcohol. The patient develops severe flushing, tachycardia, nausea, and hypotension. What is the mechanism of this reaction? Option A. Metronidazole inhibits CYP2E1, preventing alcohol metabolism. Option B. Metronidazole inhibits aldehyde dehydrogenase, causing acetaldehyde accumulation. Option C. Combined CNS depression from both substances. Option D. Metronidazole-induced gastritis aggravated by alcohol. Correct answer B. Metronidazole inhibits aldehyde dehydrogenase, similar to disulfiram, causing acetaldehyde accumulation when alcohol is consumed, leading to disulfiram-like reaction, flushing, tachycardia, nausea, vomiting, hypotension, headache. Patients must avoid alcohol during therapy and for 3 days after completion. This also occurs with some cephalosporins, cefotetin, and sulfonylureas. The reaction isn't from CNS depression or CYP2E1 inhibition. Gastritis doesn't explain the acute systemic reaction. A patient on spironolactone 50 mg daily
and lisinopril 20 mg daily for heart failure presents with weakness, palpitations, and peaked T waves on ECG. Potassium is 6.8 MEq/liter. Which recent addition most likely precipitated this crisis? Option A. Furosemide 40 mg daily, started 2 weeks ago. Option B. Metoprolol succinate 50 mg daily, started 1 month ago. Option C. Potassium chloride 20 MEq daily, started 5 days ago. Option D. Atorvastatin 40 mg daily, started 3 weeks ago. Correct answer. C. Triple potassium retaining therapy, ACE inhibitor, aldosterone antagonist, and potassium supplementation causes life-threatening hyperkalemia. The combination of spironolactone plus ACE inhibitor already increases risk. Adding potassium supplementation is dangerous and often unnecessary. Furosemide would decrease potassium. Beta blockers and statins don't significantly affect potassium. This requires immediate treatment: calcium gluconate for cardiac protection, insulin glucose, dialysis if severe, and discontinuation of potassium supplements. A patient on escitalopram 20 mg daily develops migraine headaches and is prescribed sumatriptan 50 mg as needed. After the first dose, the patient presents with agitation, tremor, hyperreflexia, and diaphoresis. What should be recognized? Option A. Migraine progression requiring higher sumatriptan dose. Option B. Serotonin syndrome from SSRI and triptan combination. Option C. Sumatriptan-induced vasoconstriction causing neurological symptoms. Option D. Allergic reaction to sumatriptan, requiring antihistamine therapy. Correct answer. B. SSRIs combined with triptans can cause serotonin syndrome, though risk is debated and many patients tolerate combination. FDA issued warning about this interaction. Presentation includes neuromuscular, tremor, hyperreflexia, clonus, autonomic, diaphoresis, hyperthermia, and mental status changes. Not all SSRI triptan combinations cause this, but awareness is critical. This isn't migraine progression or simple vasoconstriction, not allergic reaction. Management requires discontinuing serotonergic agents, supportive care, and potentially cyproheptadine. A patient taking Zalopon 10 mg at bedtime for insomnia reports the medication is too strong, causing prolonged morning sedation after starting cimetidine 400 mg twice daily for GERD. What explains this increased effect? Option A. Cimetidine inhibits CYP3A4, reducing Zalopon metabolism. Option B. Cimetidine enhances GABA receptor sensitivity. Option C. Additive CNS depressant effects from both medications. Option D. Cimetidine-induced alkalinization of urine, reducing Zalopon elimination. Correct answer. A. Cimetidine inhibits multiple CYP enzymes including CYP3A4, reducing metabolism of many drugs, including benzodiazepines and Z drugs, Zalopon, zolpidem, causing excessive sedation. Ranitidine and famotidine have minimal CYP inhibition and are preferred alternatives. Cimetidine doesn't enhance GABA receptors or cause significant CNS depression. Urinary TH doesn't affect Z drug elimination. This is a common DDI with cimetidine that often goes unrecognized. Switching H2 blockers or reducing hypnotic dose resolves the issue. A patient on everolimus 10 mg daily for renal cell carcinoma develops oral mucositis. The oncologist prescribes magic mouthwash containing viscous lidocaine. The patient develops perioral numbness, dizziness, and bradycardia. What is the concern? Option A. Lidocaine systemic absorption with everolimus inhibiting CYP3A4, causing toxicity. Option B. Everolimus-induced mucositis, increasing lidocaine absorption leading to systemic effects. Option C. Allergic reaction to lidocaine components. Option D. Combined cardiac effects from both medications.
Correct answer, B. Severe mucositis from mTOR inhibitors, everolimus, sirolimus, temsirolimus, disrupts mucosal barrier, dramatically increasing systemic absorption of topically applied medications, including lidocaine, causing CNS and cardiac toxicity. While everolimus is a CYP3A4 substrate, not inhibitor, the primary mechanism is enhanced absorption through damaged mucosa. This isn't allergic reaction. Neither drug has inherent cardiac effects. Alternative mucositis management without systemic absorption risk is needed. A patient on warfarin with stable INRs starts taking fish oil 3,000 mg daily and vitamin E 800 IU daily for heart health. 2 weeks later, INR is 4.5, and the patient has extensive bruising. What is the mechanism? Option A. Fish oil and vitamin E inhibit CYP2C9, reducing warfarin metabolism. Option B. Omega-3 fatty acids and vitamin E have antiplatelet effects additive to warfarin. Option C. Fish oil displaces warfarin from protein binding sites. Option D. Vitamin E enhances warfarin absorption from the GI tract. Correct answer, B. High-dose fish oil, omega-3 fatty acids, and vitamin E have antiplatelet, anticoagulant effects that increase bleeding risk when combined with warfarin, even with therapeutic INR. This also applies to garlic, ginkgo, and other supplements. Supplements don't significantly inhibit warfarin metabolism or affect absorption. Protein displacement is transient and clinically insignificant. Patients on anticoagulants must disclose all supplements. The additive antiplatelet effect increases bleeding risk beyond what INR reflects. A patient taking raloxifene 60 mg daily for osteoporosis prevention develops DVT requiring anticoagulation. The patient also takes cholestyramine 4 grams 3 times daily for hyperlipidemia. What administration instruction is critical? Option A. Take both medications together to enhance bone protection. Option B. Separate raloxifene and cholestyramine by at least 2 hours to prevent binding interaction. Option C. Discontinue raloxifene due to increased VTE risk. Option D. Switch cholestyramine to statin to avoid interaction. Correct answer, C. Raloxifene is a SERM that increases VTE risk, contraindicated in patients with DVT-PE history or active VTE. It must be discontinued immediately in setting of acute DVT. While bile acid sequestrants do bind raloxifene, reducing absorption, requiring separation, the primary issue is continuation of a medication that increases thrombosis risk in a patient who just developed DVT. This supersedes the binding interaction concern. Alternative osteoporosis therapy, bisphosphonate, denosumab, should be considered. A patient on lamotrigine 200 mg twice daily for bipolar disorder starts valproic acid for additional mood stabilization. 1 week later, the patient develops a diffuse erythematous rash. What is the mechanism and appropriate action? Option A. Valproic acid inhibits UGT enzymes, doubling lamotrigine levels and increasing rash risk. Reduce lamotrigine dose. Option B. Allergic cross-reactivity between antiepileptic drugs, requiring both discontinued. Option C. Valproic acid-induced thrombocytopenia, causing petechial rash. Option D. Serotonin syndrome presenting with cutaneous findings. Correct answer A. Valproic acid inhibits glucuronidation, UGT, doubling lamotrigine levels and significantly increasing Stevens-Johnson syndrome, TEN risk. Lamotrigine dose must be reduced by 50% when adding valproate, and titration must be slower. Any rash with this combination requires immediate evaluation and likely lamotrigine discontinuation given SJS, TEN risk. This isn't allergic cross-reactivity or thrombocytopenia, not serotonin syndrome. This is a critical, potentially fatal DDI requiring proactive dose adjustment when combining these medications.
A patient on edoxaban 60 milligrams daily for atrial fibrillation presents with a new MRSA skin infection. The infectious disease physician wants to start doxycycline and rifampin combination therapy. What is the pharmacist's primary concern? Option A. Rifampin induces peak glycoprotein, reducing edoxaban levels and increasing stroke risk. Option B. Doxycycline chelates with edoxaban, reducing anticoagulant efficacy. Option C. Combined QT prolongation from both antibiotics with edoxaban. Option D. Rifampin inhibits CYP3A4, increasing edoxaban and bleeding risk. Correct answer. A. Rifampin potently induces peak glycoprotein, edoxaban's primary elimination pathway, dramatically reducing edoxaban levels by 30 to 40% and compromising anticoagulation. Edoxaban is contraindicated with rifampin. Alternative anticoagulation, warfarin, is less affected, or alternative antibiotics should be considered. Doxycycline doesn't chelate with edoxaban. It chelates with divalent cations. Neither antibiotic significantly prolongs QT. Rifampin induces, not inhibits, CYP enzymes. This interaction puts patients at serious risk for thromboembolic events. A patient taking memantine 10 mg twice daily for Alzheimer's disease starts sodium bicarbonate 650 mg 3 times daily for chronic metabolic acidosis. The patient develops increased confusion, agitation, and hallucinations. What explains this deterioration? Option A. Sodium bicarbonate inhibits CYP metabolism, increasing memantine levels. Option B. Urinary alkalinization from bicarbonate reduces renal memantine elimination, causing accumulation. Option C. Combined anticholinergic effects from both medications. Option D. Sodium bicarbonate displaces memantine from NMDA receptor binding. Correct answer, B. Memantine is renally eliminated unchanged and is pH dependent. Alkaline urine from sodium bicarbonate, acetazolamide reversal, increases tubular reabsorption, reducing clearance and causing toxicity, confusion, agitation, hallucinations, dizziness. Acidic urine enhances elimination. Memantine isn't metabolized by CYP enzymes. Neither drug has significant anticholinergic effects. Bicarbonate doesn't affect receptor binding. This is a clinically significant interaction in patients requiring urinary alkalinization or those taking carbonic anhydrase inhibitors. A patient on clozapine 450 mg daily with stable levels around 520 nanograms per milliliter starts oral contraceptives, ethinyl estradiol, drospirenone. 4 weeks later, clozapine level is 780 nanograms per milliliter, with severe sedation and hypersalivation. What is the mechanism? Option A. Estrogen inhibits CYP1A2, reducing clozapine metabolism. Option B. Progestin component enhances clozapine absorption. Option C. Estrogen induces CYP3A4, converting clozapine to toxic metabolites. Option D. Combines sedative effects from hormonal and antipsychotic therapy. Correct answer, A. Estrogen-containing contraceptives inhibit CYP1A2, reducing clozapine metabolism and increasing levels, potentially causing toxicity, sedation, hypersalivation, seizures, agranulocytosis. This is opposite to the smoking interaction, induction. Clozapine dose may need reduction when starting OCPs. Progestins don't enhance absorption. Estrogen doesn't induce CYP3A4 or create toxic metabolites. OCPs don't have significant sedative effects. Women stopping OCPs on clozapine require close-level monitoring and dose adjustment. A patient on aliskiren 150 mg daily for hypertension develops acute kidney injury with creatinine rising from 1.1 to 3.2 mg per deciliter and potassium of 6.1 MEq per liter. The medication list shows recent addition of ibuprofen 600 mg 3 times daily for back pain.
What mechanism contributed to this renal crisis? Option A. Ibuprofen inhibits CYP3A4, increasing aliskiren levels. Option B. Combined RAAS blockade with NSAID-induced afferent arterial constriction, causing severe GFR reduction. Option C. Ibuprofen displaces aliskiren from renin binding sites. Option D. Direct tubular toxicity from combined medications. Correct answer, B. Aliskiren, direct renin inhibitor, blocks RAAS, causing efferent arterial dilation. NSAIDs inhibit prostaglandin synthesis, causing afferent arterial constriction. Combined effects drastically reduce GFR and can precipitate acute kidney injury, especially with volume depletion. Both also cause potassium retention. This interaction also occurs with ACE inhibitors and ARBs. Ibuprofen doesn't affect aliskiren metabolism or receptor binding. The mechanism is hemodynamic, not direct toxicity. NSAIDs should be avoided in patients on RAAS inhibitors. A patient taking fentanyl patches 75 micrograms per hour for chronic cancer pain reports breakthrough pain requiring frequent rescue doses after starting modafinil for cancer-related fatigue. What explains this reduced analgesia? Option A. Modafinil induces CYP3A4, increasing fentanyl metabolism and reducing levels. Option B. Modafinil antagonizes opioid receptors through wake-promoting mechanisms. Option C. Modafinil enhances P-glycoprotein efflux, reducing fentanyl CNS penetration. Option D. Modafinil-induced hypermetabolism increases pain perception. Correct answer. A. Modafinil is a moderate CYP3A4 inducer that can reduce levels of CYP3A4 substrates, including fentanyl, potentially causing inadequate analgesia and breakthrough pain. Fentanyl dose may need adjustment. This also affects other CYP3A4 substrates, contraceptives, cyclosporin, midazolam. Modafinil doesn't antagonize opioid receptors or significantly affect PGP. Hypermetabolism doesn't reduce opioid efficacy. Breakthrough pain in patients starting enzyme inducers requires reassessment of opioid regimen and possible dose increase. A patient on phenytoin 300 mg daily with levels stable at 14 micrograms per milliliter starts enteral feeding via nasogastric tube. 2 weeks later, phenytoin level is 6 micrograms per milliliter, and the patient has a seizure. What is the most likely explanation? Option A. Enteral formula inhibits CYP2C9, reducing phenytoin metabolism. Option B. Enteral formula binds phenytoin in the GI tract, reducing absorption. Option C. Nasogastric tube placement altered phenytoin pharmacokinetics. Option D. Protein in formula displaces phenytoin from binding sites, increasing clearance. Correct answer, B. Enteral nutrition formulas, especially protein components, calcium, bind phenytoin, dramatically reducing absorption and causing subtherapeutic levels and breakthrough seizures. Administration should be separated. Hold feeding 1 to 2 hours before and after phenytoin. Some recommend changing to IV phenytoin during continuous feeds. Formulas don't inhibit metabolism. Tube placement itself doesn't alter kinetics. Protein displacement increases free levels transiently, but doesn't explain sustained low total levels. This is a critical, often missed interaction in ICU hospitalized patients. A patient on verapamil 240 mg daily for hypertension develops muscle weakness, elevated CK 8,500 UL, and dark urine after starting simvastatin 40 mg at bedtime. Why is verapamil particularly problematic with statins? Option A. Verapamil induces CYP3A4, converting simvastatin to toxic metabolites. Option B. Verapamil inhibits CYP3A4 and P-glycoprotein, increasing simvastatin levels. Option C. Combined muscle effects from calcium channel blockade and HMG-CoA inhibition. Option D. Verapamil-induced hypotension reduces muscle perfusion, worsening statin myopathy. Correct answer, B. Verapamil inhibits both CYP3A4 and P-glycoprotein, significantly increasing levels of simvastatin, most susceptible, and lovastatin, causing rhabdomyolysis. Maximum simvastatin dose with verapamil is 10 mg daily. Diltiazem has similar interaction. Alternatives include pravastatin, rosuvastatin, or pitavastatin, not CYP3A4 substrates. Verapamil doesn't induce enzymes or create toxic metabolites. The mechanism isn't additive muscle effects or perfusion-related. This is a common preventable interaction requiring dose limitation or alternative statin selection. A patient on sacubitril valsartan, 97/103 mg twice daily for heart failure with reduced ejection fraction, is being bridged from lisinopril. How long must elapse between the last lisinopril dose and first sacubitril valsartan dose? Option A, 12 hours to prevent additive hypotension. Option B, 36 hours to prevent life-threatening angioedema from dual neprilysin and ACE inhibition. Option C, 24 hours to allow ACE inhibitor washout. Option D, 48 hours to prevent hyperkalemia from combined RAAS blockade. Correct answer, B. Sacubitril inhibits neprilysin, breaks down bradykinin. ACE inhibitors also increase bradykinin. Combined effects dramatically increase angioedema risk, which can be fatal. A 36-hour washout is mandatory when switching from ACE inhibitor to sacubitril valsartan. ARNIs are contraindicated with ACE inhibitors or within 36 hours of last dose. While hypotension and hyperkalemia are concerns, angioedema is the critical life-threatening risk. This is an absolute contraindication, requiring strict adherence to washout period. A patient taking levothyroxine 88 micrograms daily and stable on therapy starts taking a fiber supplement, psyllium, with breakfast, along with all morning medications. 6 weeks later, TSH is 8.9 MIU per liter. What is the appropriate intervention? Option A, increase levothyroxine to 100 micrograms daily. Option B, take levothyroxine at least 4 hours before or after fiber supplement. Option C, switch to desiccated thyroid to overcome the interaction. Option D, take fiber supplement at bedtime only. Correct answer, B. Fiber supplements, especially psyllium, bind levothyroxine in the GI tract, reducing absorption. This also occurs with soy products, coffee, and other binding agents. Levothyroxine should be taken on empty stomach, separated from interfering substances by 4+ hours. Simply increasing dose doesn't address ongoing binding. Switching thyroid preparations doesn't solve absorption problem. Moving fiber to bedtime doesn't help if levothyroxine timing isn't corrected. Consistent timing and separation from interacting substances is critical for stable thyroid control. A patient on duloxetine 60 mg daily for diabetic neuropathy starts tramadol 50 mg 4 times daily for breakthrough pain. The patient presents with restlessness, tremor, hyperreflexia, and fever of 38.9 degrees Celsius. What is the most urgent intervention? Option A, reduce duloxetine dose by 50% and continue tramadol. Option B, discontinue both serotonergic agents immediately and provide supportive care. Option C, add propranolol to control hyperadrenergic symptoms. Option D, switch tramadol to oxycodone to eliminate interaction. Correct answer B. This is serotonin syndrome from SNRI plus tramadol, dual serotoninergic medications. Immediate discontinuation of causative agents is essential. Supportive care includes cooling, benzodiazepines for agitation, and cyproheptadine in severe cases. Continuing either medication is dangerous, as syndrome can progress to seizures, hyperthermia, rhabdomyolysis, and death. Propranolol may worsen by blocking compensatory vasodilation. While switching to pure opioid eliminates future risk, immediate crisis management requires stopping both agents. This combination should generally be avoided. A patient on diltiazem 240 mg ER daily develops new-onset atrial fibrillation, requiring digoxin for rate control. After starting digoxin 0.25 mg daily, the patient presents with nausea, yellow-green vision changes, and an irregular pulse. Digoxin level is 2.8 nanograms per milliliter. What mechanism caused this toxicity? Option A. Diltiazem inhibits CYP3A4, increasing digoxin metabolism to toxic forms. Option B. Diltiazem inhibits P-glycoprotein, reducing renal digoxin elimination. Option C. Additive AV nodal suppression, increasing digoxin sensitivity. Option D. Diltiazem-induced hypokalemia potentiating digoxin toxicity. Correct answer, B. Diltiazem and verapamil inhibit P-glycoprotein, reducing renal digoxin clearance and causing accumulation and toxicity, nausea, vision changes, arrhythmias. Digoxin dose should be reduced 25 to 50% when starting non-DHP CCBs. Digoxin isn't significantly metabolized by CYP enzymes. While both suppress AV node, this doesn't explain elevated digoxin levels. CCBs don't cause hypokalemia, diuretics do. Close monitoring and empiric dose reduction is necessary when combining these medications. A patient on dasatinib 100 mg daily for chronic myeloid leukemia develops severe gastroesophageal reflux. The oncologist hesitates to prescribe a PPI. What is the primary concern with adding omeprazole? Option A. Omeprazole inhibits CYP3A4, increasing dasatinib levels and toxicity. Option B. Gastric pH elevation from PPI reduces dasatinib absorption, potentially causing treatment failure. Option C. Combined QT prolongation from both medications. Option D. Omeprazole induces P-glycoprotein, reducing dasatinib efficacy. Correct answer, B. Tyrosine kinase inhibitors like dasatinib require acidic pH for optimal absorption. PPIs significantly reduce absorption by increasing gastric pH, potentially compromising cancer treatment. If acid suppression needed, H2 antagonists taken separately stagger by 2 and more hours, or antacids are preferred. This also affects erlotinib, gefitinib, and pazopanib. Omeprazole doesn't increase dasatinib levels. While dasatinib prolongs QT, omeprazole doesn't. PPIs don't induce PGP. Oncologic efficacy takes precedence, so alternative acid suppression strategies are critical. A patient on chronic opioid therapy with morphine ER 60 mg twice daily reports sudden onset severe pain and opioid withdrawal symptoms, sweating, agitation, dilated pupils, after taking a single dose of a new prescription. Which medication most likely caused this reaction? Option A. Ibuprofen 800 mg for breakthrough pain. Option B. Ondansetron 8 mg for nausea. Option C. Buprenorphine naloxone 8 to 2 mg sublingual given in ED. Option D. Gabapentin 300 mg for neuropathic pain. Correct answer, C. Buprenorphine is a partial mu opioid agonist with high receptor affinity. When given to patients on full agonists, morphine, oxycodone, hydromorphone, it displaces the full agonist and precipitates acute withdrawal due to its lower intrinsic activity. This is called precipitated withdrawal and requires cautious introduction with dose reduction, discontinuation of full agonists. Ibuprofen, ondansetron, and gabapentin don't cause withdrawal. This is a critical error in opioid management, requiring recognition and prevention. A patient stabilized on quetiapine 400 mg at bedtime starts carbamazepine 200 mg twice daily for newly diagnosed epilepsy. 2 weeks later, the patient reports worsening hallucinations and paranoia. Quetiapine levels are subtherapeutic. What explains this psychiatric deterioration? Option A. Carbamazepine antagonizes dopamine receptors, reducing quetiapine efficacy. Option B. Carbamazepine induces CYP3A4, dramatically reducing quetiapine levels. Option C, competitive binding at serotonin receptors. Option D, carbamazepine-induced hyponatremia causing psychiatric symptoms. Correct answer, B. Carbamazepine potently induces CYP3A4, dramatically reducing quetiapine levels up to 85% and causing loss of antipsychotic efficacy with breakthrough psychosis. Significant dose increase, potentially double or more, is necessary, or alternative antiepileptics should be considered. Carbamazepine doesn't antagonize dopamine receptors or compete at serotonin sites. While carbamazepine can cause hyponatremia, the primary issue is pharmacokinetic induction, causing treatment failure. This combination requires close monitoring and substantial dose adjustment. A patient on warfarin with stable INRs develops hyperthyroidism and is started on methimazole 15 mg 3 times daily. 4 weeks later, INR increases to 5.8. What mechanism explains this change? Option A. Methimazole inhibits CYP2C9, reducing warfarin metabolism. Option B. Correction of hyperthyroid state reduces metabolic clearance of clotting factors, increasing warfarin effect. Option C. Methimazole enhances warfarin absorption from improved GI motility. Option D. Thyroid hormone reduction decreases vitamin K synthesis. Correct answer, B. Hyperthyroidism increases metabolism and clearance of vitamin K-dependent clotting factors, requiring higher warfarin doses. As hyperthyroidism is treated, methimazole, radioactive iodine, thyroidectomy, metabolism normalizes, clotting factors persist longer, and INR increases. Warfarin dose typically needs reduction as patient becomes euthyroid. Methimazole doesn't significantly inhibit CYP2C9. The mechanism is indirect through thyroid state normalization, not enhanced absorption or vitamin K synthesis changes. Close INR monitoring is essential during thyroid treatment. A patient taking duloxetine 60 mg daily and linezolid 600 mg twice daily for osteomyelitis develops agitation, confusion, tremor, and hyperthermia. What property of linezolid caused this interaction? Option A. Linezolid is a potent CYP2D6 inhibitor, increasing duloxetine levels. Option B. Linezolid has weak MAO inhibitor properties, potentiating serotonergic effects. Option C. Linezolid depletes vitamin B6, affecting serotonin synthesis. Option D. Linezolid inhibits P-glycoprotein, enhancing duloxetine CNS penetration. Correct answer, B. Linezolid is a weak, non-selective MAO inhibitor, mechanism for some adverse effects, including thrombocytopenia. Combined with serotonergic drugs, SSRIs, SNRIs, TCAs, tramadol, meperidine, it can cause serotonin syndrome. This combination should generally be avoided. If necessary, use lowest SNRI, SSRI dose and monitor closely. Linezolid doesn't significantly inhibit KIP2D6 or PGP. Vitamin B6 depletion causes peripheral neuropathy, not serotonin syndrome. This is an under-recognized serious interaction requiring awareness. A patient on ticagrelor 90 mg twice daily after coronary stent placement requires strong pain control. The cardiologist advises against morphine. What is the concern with combining ticagrelor and morphine? Option A. Morphine causes gastroparesis, delaying ticagrelor absorption and reducing antiplatelet effect. Option B. Ticagrelor inhibits CYP metabolism, increasing morphine levels. Option C. Combined bleeding risk from morphine's antiplatelet properties. Option D. Morphine antagonizes P2Y12 receptors, reducing ticagrelor efficacy. Correct answer A. Morphine and other opioids slow gastric emptying, delaying oral antiplatelet absorption and reducing peak levels, potentially compromising early antiplatelet effects critical in acute coronary syndromes. This is particularly concerning with ticagrelor and prasugrel in STEMI. IV antiplatelet loading or alternative analgesics, fentanyl has less GI effect, may be considered. Ticagrelor doesn't inhibit morphine metabolism. Morphine doesn't have antiplatelet properties or affect P2Y12 receptors. This interaction has clinical implications in ACS management. A patient on rosuvastatin 20 mg daily starts taking red yeast rice supplements recommended by a friend for additional cholesterol lowering. The patient develops severe muscle pain and CK elevation of 14,000 U-liters. What explains this toxicity? Option A, red yeast rice inhibits CYP metabolism, increasing rosuvastatin levels. Option B, red yeast rice contains monocolin K, identical to lovastatin, causing additive statin exposure. Option C, combined depletion of coenzyme Q10 from both supplements. Option D, red yeast rice enhances rosuvastatin absorption through bile acid effects. Correct answer, B. Red yeast rice naturally contains monocolin K, which is chemically identical to lovastatin, a statin. Taking it with prescription statins causes additive statin exposure and significantly increases myopathy, rhabdomyolysis risk. Many patients don't realize it's a statin. Red yeast rice doesn't affect CYP metabolism of rosuvastatin, not CYP metabolized. Why CoQ10 depletion is proposed in statin myopathy, the mechanism here is dual statin therapy. Patients on statins should avoid red yeast rice supplements completely. A patient taking posaconazole, 300 mg twice daily for invasive aspergillosis, is started on rifabutin for MAC prophylaxis. The patient develops breakthrough fungal infection, and posaconazole levels are subtherapeutic. What is the appropriate action? Option A, increase posaconazole dose to overcome induction. Option B, this combination should be avoided. Use alternative antimycobacterial therapy. Option C, add a second antifungal to compensate for reduced levels. Option D, switch to oral voriconazole, which isn't affected by rifabutin. Correct answer, B. Rifabutin, like rifampin, induces CYP3A4 and other enzymes, dramatically reducing azole levels and causing treatment failure of serious fungal infections. This combination should be avoided. Alternative antimycobacterials, azithromycin for MAC, are preferred. Increasing posaconazole may not overcome potent induction. Adding another antifungal increases toxicity without addressing the interaction. Voriconazole is also affected by rifamycins. The reverse interaction also occurs. Azoles inhibit rifabutin metabolism, causing toxicity, uveitis. When both needed, therapeutic drug monitoring and specialist consultation are essential. A patient on venlafaxine 225 mg daily develops hypertension, and the physician wants to start clonidine. What is the concern with this combination? Option A, clonidine inhibits CYP2D6, increasing venlafaxine levels and serotonin syndrome risk. Option B, venlafaxine's norepinephrine reuptake inhibition may reduce clonidine's antihypertensive efficacy. Option C, combined sedation from both medications. Option D, clonidine withdrawal risk increased by venlafaxine's cardiovascular effects. Correct answer, B. Venlafaxine SNRI inhibits norepinephrine reuptake at higher doses, 150 mg, potentially reducing efficacy of clonidine, alpha-2 agonist that works by reducing norepinephrine release. While not absolutely contraindicated, efficacy may be reduced and alternative antihypertensives might be preferred. Clonidine doesn't significantly inhibit KYP2D6. Venlafaxine isn't highly sedating. While clonidine withdrawal is concerning, venlafaxine doesn't uniquely increase this risk. This represents a potential pharmacodynamic antagonism requiring monitoring of blood pressure response. A patient on chronic benzodiazepine therapy with lorazepam 2 mg 3 times daily is switched to diazepam for long-acting coverage. The new dose is diazepam 10 mg 3 times daily. The patient develops severe sedation and respiratory depression, requiring ICU admission. What was the error? Option A, diazepam has active metabolites causing accumulation, unlike lorazepam. Option B, the diazepam dose was too high. Equivalent dose should have been approximately 5 mg 3 times daily. Option C, diazepam inhibits CYP metabolism of residual lorazepam. Option D, patient developed paradoxical excitation requiring higher sedation. Correct answer B. Benzodiazepine equivalency. Lorazepam 1 mg, approximately diazepam 5 mg. Converting 2 mg lorazepam TID to 10 mg diazepam TID represents a twofold overdose, should be around 5 mg TID. While diazepam does have active metabolites, desmethyldiazepam, contributing to long duration, the primary error was dose conversion. Diazepam doesn't inhibit lorazepam metabolism. This wasn't paradoxical excitation. Proper benzodiazepine equivalency calculations are critical to prevent overdose when switching formulations or agents. A patient on chronic tacrolimus therapy for heart transplant develops a UTI. The patient takes cranberry juice daily and significantly increases intake during the infection. Tacrolimus level increases from 8 nanograms per milliliter to 16 nanograms per milliliter. What is the mechanism? Option A, cranberry juice inhibits CYP3A4, reducing tacrolimus metabolism. Option B, increased fluid intake diluted tacrolimus binding proteins. Option C, cranberry juice inhibits P-glycoprotein, increasing tacrolimus absorption. Option D, urinary acidification from cranberry, enhanced tacrolimus reabsorption. Correct answer, A. Cranberry juice can inhibit CYP3A4 and possibly PGP, increasing levels of immunosuppressants and other CYP3A4 substrates. While effect varies and isn't as potent as grapefruit, it's clinically significant in narrow therapeutic index drugs like tacrolimus. Transplant patients should maintain consistent cranberry intake or avoid it. Fluid intake doesn't significantly dilute binding proteins. While cranberries acidify urine, may prevent UTIs, tacrolimus isn't reabsorbed based on urinary pH. Consistent dietary intake is important for immunosuppressant level stability. A patient on warfarin with stable INRs is started on testosterone cypionate, 200 mg IM every 2 weeks for hypogonadism. 4 weeks later, INR increases to 5.2 with gingival bleeding. What is the mechanism of this interaction? Option A, testosterone inhibits CYP2C9, reducing warfarin metabolism. Option B, androgens decrease synthesis of vitamin K-dependent clotting factors, increasing warfarin sensitivity. Option C, testosterone displaces warfarin from albumin binding sites. Option D, IM injection trauma, increased bleeding manifestations. Correct answer, B. Androgens, testosterone, methyltestosterone, danazol decrease hepatic synthesis of clotting factors, particularly 2, 7, 9, 10, potentiating warfarin effect and increasing bleeding risk. Warfarin dose typically needs reduction when starting androgens. The reverse occurs when stopping androgens. INR may decrease. Testosterone doesn't significantly inhibit CYP2C9. Protein displacement is transient and insignificant. IM trauma might cause localized bleeding, but doesn't explain systemic INR elevation. Close INR monitoring is essential when initiating or discontinuing androgen therapy. A patient on phenytoin 400 mg daily with levels stable at 16 micrograms per milliliter starts disulfiram for alcohol use disorder. 1 week later, phenytoin level is 32 micrograms per milliliter with ataxia, nystagmus, and confusion. What is the mechanism of this toxicity? Option A. Disulfiram inhibits CYP2C9, reducing phenytoin metabolism. Option B. Alcohol abstinence improved phenytoin absorption. Option C. Disulfiram displaced phenytoin from protein binding sites. Option D. Disulfiram induced hepatotoxicity, reduced phenytoin clearance. Correct answer A. Disulfiram inhibits CYP2C9, an aldehyde dehydrogenase, significantly reducing phenytoin metabolism and causing toxicity. Phenytoin dose should be reduced, often 25 to 30% when starting disulfiram, and levels monitored closely. Phenytoin toxicity presents with CNS effects, ataxia, nystagmus, confusion, diplopia. Alcohol abstinence doesn't improve absorption. Protein displacement doesn't explain sustained elevation. While disulfiram can cause hepatotoxicity, the primary mechanism is enzyme inhibition. This is a significant, predictable interaction requiring proactive dose adjustment. A patient on dabigatran 150 mg twice daily for atrial fibrillation undergoes elective surgery and is started on dronedarone 400 mg twice daily postoperatively for rhythm control. The patient develops severe bleeding from surgical site with hemoglobin drop from 12 to 8 grams per deciliter. What explains this hemorrhage? Option A. Dronedarone inhibits CYP3A4, increasing dabigatran metabolism to active forms. Option B. Dronedarone inhibits P-glycoprotein, dramatically increasing dabigatran levels. Option C. Additive QT prolongation causing coagulopathy. Option D. Surgical stress reduced dabigatran renal clearance. Correct answer B. Dronedarone is a strong P-glycoprotein inhibitor. Dabigatran is a PGP substrate, not CYP metabolized. This combination causes dramatic dabigatran accumulation and severe bleeding risk. Dabigatran dose should be reduced to 75 mg BID with dronedarone, or alternative anticoagulation considered. This contraindication is often missed. Dronedarone doesn't increase metabolism to active forms. Dabigatran etexylate is the prodrug converted to active dabigatran. QT prolongation doesn't cause bleeding. While renal function affects dabigatran, the primary issue is PGP inhibition preventing intestinal efflux and renal elimination. Great work! Challenging? That's a good sign. Rewatch any section where you struggled and continue practicing with the other drug interaction videos in this series to strengthen pattern recognition. Subscribe to MedPrepPrime for more pharmacist-led, exam-style practice designed to prepare you for how the NAPLEX actually tests.